So there's of course a lot of trials each year at ASH, and you know, we can certainly discuss those. But I would maybe start by a few of the things that caught my attention regarding things that one can do today, or that inform practice today. So, for example, you know, there was a presentation from Europe, Claire Harrison and others in her group, about CALR VAF dynamics. So as you treat ET patients with ruxolitinib or interferon or anagrelide or hydroxyurea, what happens to the CALR variant allele frequency? And somewhat expectedly, we saw that with ruxolitinib and interferon it goes down, whereas with anagrelide and hydroxyurea it goes up. That of course is not surprising and actually sort of vindicates what we think. But something provocative that was brought up was that we've known, for example, that anagrelide can cause an increase in bone marrow fibrosis, and what is intriguing is, could that be because it's increasing CALR VAF? We know that CALR is one of the mutations that does increase propensity to developing bone marrow fibrosis. So I found that actually very intriguing. Now, a brief mention of Fedratinib, which is a commercially available agent. There were two presentations, one from Andrew Kirkendall of Moffitt from an investigator-sponsored trial in MDS MPN overlap. So it's really nice to see something being done in that space, which really doesn't have a clear standard of care, and clearly Fedratinib is an active agent. And then also from the Freedom 2 study, which is post-ruxolitinib myelofibrosis patients, already published in the Lancet Hematology by Claire Harrison and others. But in the oral presentation at this meeting from Dr. Al-Ali, the focus was on low platelet patients, those between 50 and 99,000 baseline platelets, and really goes to show that Fedratinib absolutely preserves its efficacy in this group of patients. It might even be better than in patients with 100 and higher platelets. Normally you assume that the lower platelets are the harder ones to treat, and that is a fact. And but here, you know, somewhat refreshingly and surprisingly, you're seeing as good and perhaps better responses with Fedratinib for spleen, for example, in this lower platelet subgroup. Now, this does agree with what we already knew from Jakarta, but the Freedom trials have, you know, the Freedom 2 trial specifically has a much larger sample size. And then I'll just quickly mention that there was a very interesting presentation by Francesca Pellandri from Italy on really looking at maybe if we should rethink, I think we all agree that we should rethink the risk stratification of polycythemia vera. And so they were looking at a number of factors that may inform our decision making and risk stratification beyond the usual age and prior thrombosis, which we have known for a long time. And I'll conclude by saying there was also a very interesting presentation on pulmonary hypertension in myelofibrosis, which we all know happens and can be a difficult problem for our patients. But this particular trial, what caught my attention was that this study that I really noted was that the pulmonary hypertension can actually also correlate with hematologic progression beyond cardiovascular complications, which obviously are going to happen, but also correlated with hematologic progression, just drawing more attention to what is a difficult problem in our patients.